Hi, everyone. We're going to get started again. Next, I have the honor of introducing Dr. Lola Fayanju, who is the Associate Professor of Surgery and Population Health Sciences at Duke University School of Medicine, Associate Director of Duke Forge, and Director of the Durham Veterans Affairs Breast Clinic, presenting on diversity, representativeness, and the importance, of inclusive research. So welcome, Dr. Fayanju.
Thank you so much. I first of all have to congratulate Cecilia on pronouncing my first name better than any non-Nigerian I think I've ever heard. So thank you for taking the time to do that. I'll go ahead and share my screen. Again, thank you for having me today. I'm very excited to be here. Other than the funding listed here, I have no disclosures. So in beginning my talk, I want to start with a couple of definitions. First, with diversity. That term is thrown around a lot, but as we all know, diversity can mean a variety of things. It represents range, represents inclusion ideally, as well as heterogeneity and mixture. And it's a characteristic that we all think of. I think attending this conference is something that's good to have. And the question is it good for its own sake? Why do we value diversity? And why do we think it's something that needs to characterize not only the world in which we live, but the research that we do? Then I wanted to talk a little about representativeness or representation. Hannah Pitkin is a political theorist at Berkeley, whose seminal book, The Concept of Representation, was really groundbreaking because it decided to move the field of political philosophy from thinking about representation as simply resembling the people that you are in front of representing, but actually acting on their behalf or acting in their own interests. And so when you think about the different ways in which you can represent a group, you can either represent the group because you seem to be an example of the kind of person that is in that group. That is, you are a microcosm of that group. You can be a trustee of that group. That is someone who is acting on behalf of a group or behalf of an individual, like the ward of a state. Or you can also be a delegate. That is, you are chosen in some way by the group to advocate for their preferences. And the question is, where do we lie as curators and creators of research with regards to the intersection of these three different ways of being representative? And should we be at the intersection, or is there one of these three roles that we should preferentially occupy? Now, many of you may know of the song This Land Is Your Land, which is by Woody Guthrie, and is often thought of as a kind of kumbaya testament to the American spirit and to the United States. But in fact, it was a fairly controversial song. It was created to celebrate the geographic beauty of the United States, but it was also a call for social justice, highlighting the ways in which capitalism was changing the shape of a country just barely recovering from the Great Depression. And notably, these last two verses, which are not as commonly sung in schools and at patriotic events, really highlight the idea that while this land is here, is it really made for the average American? Is it really made for you and me? A few more terms to describe. First, disparity. A disparity is an observed intergroup difference in health screening outcomes and or treatment that is not related to the baseline prevalence of a disease or the culturally prescribed preferences of a group. It is fundamentally unjust. And therefore, we would like to believe in a world that celebrates justice, that it's something that can be avoided. It's a difference that shouldn't be there, that we should be working to redress. Now, health equity, on the other hand, represents the idea that health should be distributed according to clinical need. That is, it shouldn't be hoarded by some and deprived from others based on preferences about who deserves things more. It represents the idea of equal opportunities to use of healthcare resources. But for us to be able to reject disparity as a form of injustice and to embrace health equity as a form of justice, we of course need to agree that we actually have a common view of justice. And despite the fact that we're all at this conference together, trying to think about how we can embrace justice as a tenet within research, we have to recognize that many of the people with whom we are collaborating and to whom we're trying to communicate our research may not have the same shared values. Now, with regards to disparities in research, one question is there a problem? And you'd be surprised how many individuals do not think that is the case. With regards to clinical trials, we know that African Americans represent only 13% of the United States, but historically it only represented 5% of those in clinical trials. Now, notably, that number has recently been revised to something like 14%. As I'll explain in a minute, the types of trials in which there is under and overrepresentation are relatively problematic. Likewise, Hispanic and Latinx individuals represent only 7 to 8% of those in clinical trials, while representing a fifth of the United States population. And quite concerningly, underrepresentation in cancer clinical trials is the case even for cancers in which there's a higher prevalence amongst people of color, such as multiple myeloma. And even more disturbingly, African American and Latinx individuals are overrepresented in phase 1 trials and underrepresented in phase 3 trials. That is, phase 1 trials, which are typically the first in human trials, where the stakes are highest in terms of demonstrating safety, but frankly, the likelihood of demonstrating efficacy individually or at a cohort level is lower. We have more people of color. In contrast, in phase 3 trials, where the likelihood of individual benefit is highest and the most vetting has been done and the least individual risk is posed to its participants, we have underrepresentation of people of color. And finally, African Americans are much more likely to participate in trials that are what we call accepted from informed consent. That is, trials for which emergency application of an intervention is required, such that it is impossible or incredibly difficult to obtain informed consent from the individuals participating in the trial or their family members. An example would be if there are, for instance, competing ways in which to perform CPR on someone who's about to die, or to provide a life-sustaining blood transfusion. It is almost impossible to obtain informed consent in those circumstances. And unfortunately, African Americans represent about 29% of those who participate in those trials, despite the fact that across the country, they represent about 10% of those in all trials. Now, when we look at these types of disparities in representation and see the ways in which disparities not only represent how people are viewed across all trials in general, but the types of research we find people overrepresented amongst, we have to think to ourselves, are we, as those who consent people for trials, exploiting therapeutic misconception? That is, in order to get people to join the trials that we want them to be in, are we sometimes failing to convey the goals of phase 1 studies? And are we failing to take seriously how a patient might view enrollment in a trial as a last-ditch effort, as a way to get healthcare they otherwise would not receive? And are we using that to basically get people into trials that are a little bit harder to convince good subjects, quote unquote, to participate in, while biasing our phase 3 studies to individuals who are healthier, more resourced, and frankly, easier to include in clinical trials? And even if you look at the level of health services research, that is research that uses population-based databases, we find that there is even a concern about equity and representation amongst those. The SEER database from the CDC is limited to less than half of states, and it is a population-based type of database. However, you can imagine that there are still swaths of the United States that are not properly included or properly represented amongst the SEER data. The National Cancer Database is actually not a population-based database because it sources data from hospitals that belong to the Commission on Cancer, which is jointly run by the American Cancer Society and the American College of Surgeons. And as a result of these hospitals being the source of the data rather than state-run agencies, it means there's a bias towards the types of patients that are included. That is, they're the kinds of patients who are going to Commission on Cancer accredited institutions, which we know are more likely to be well-resourced in areas where there are higher levels of insurance. And so we already are aware that there are people of color and uninsured people who are under-captured by these types of hospitals and therefore underrepresented in the National Cancer Database, which is currently the largest set of data on cancer available to health services researchers in the United States. Now, what's at stake when we don't have representation in research? And for whom are these stakes high? In 1993, which seems like a long bygone period of bipartisan collaboration, the United States Congress actually passed an act that was meant to encourage participation of women and racial and ethnic minorities in NIH-sponsored research. And since then, we've tried to see whether or not there's actually been an improvement in representation as a result of this legislation. I want to take you back to summer of 2020, when the first trial came out from the New England Journal of Medicine describing how efficacious a vaccine might be with regards to the COVID-19 virus. Now, this first phase 1 trial, which was published with great fanfare, was looking at whether or not we needed to have 2 types of vaccinations, that is, initial shot and a booster, how far apart they needed to be, which was basically thought to be 28 days, and what types of dosing were needed. And overall, the results were hailed as a success. Small study, as many phase 1 studies are, but they did see a dose-dependent increase in antibody titers after both sets of vaccinations. And best of all, it seemed that the neutralizing activity of the vaccine seemed to approximate what was seen in people who had actually had the COVID-19 infection. We did see higher side effects with people who got the second dose, as many of us have experienced, and also when there were higher doses of the drug. So overall, this was thought to be a very successful phase 1 trial. There were no trial limiting safety concerns, and the feeling was that we were well underway and ready to proceed to phase 2 of the trial. However, 89% of the participants in this trial were white. And as we know, that has not been the face of the COVID-19 pandemic. Initially referred to as the great equalizer, we actually have now found that COVID-19 was the great revealer. That is, it was something that basically highlighted the disproportionate effect that COVID-19 had on ethnic minorities in diverse countries such as the United States, Canada, and the United Kingdom. We know that across major metropolitan areas, there are disproportionate representation of people of color amongst infections and deaths. And we also know that amongst our indigenous population, if, for instance, the Navajo Nation were compared to any single state, it would have had the highest rate of infection per capita from COVID-19. And that's just what's reported. Concerningly, we have not had universal testing and reporting of infections and deaths by race and ethnicity. Yes, we had infections by race and ethnicity reported in almost all states, as well as deaths, but only 6 states reported testing, which is of course critical because it means we then can know whether people died as a result of COVID-19. But if people were never diagnosed in the first place, it's impossible to ascribe their death to the virus unless an autopsy was specifically directed at eliminating or confirming COVID-19 infection. When we go back to the results of this landmark trial published in the New England Journal of Medicine, conducted amongst participants recruited from diverse cities such as Cambridge, Massachusetts, and Seattle, Washington, and then reflect on the fact that 89% of the trial participants were white for a disease that disproportionately affects people of color, you have to ask yourself, who is at the table when important decisions about research are being made? Health disparities research is hard to do, and it's hard to do well, for a variety of reasons, including, can we all agree upon the definitions of the terms that we're using and how we're using them? The scale at which trials need to be conducted means that we need to have sufficient numbers of individuals in order to sufficiently power a trial to detect differences between groups. Conflicting stakeholder priorities is important. What is important to researchers, to funding agencies, patients is not always the same. And the nexus of power may often be such that even if a particular group has a vested interest in a condition that is disproportionately affecting a particular group, if there isn't the funding and the power to support that research, it may not take place. In addition, within healthcare, it might be that in order to answer some of the important questions we have with regards to disparities, we may need to collaborate with individuals and use methods that we are unused to employing, including qualitative methods as well as ethnography. In addition, we can't simply be looking for significant p-values at the end of our research with regards to whether there's a signal, quote unquote, in how ethnic and racial minorities are doing in a particular trial. An attention to disparity and a focus on how disparity might play itself out needs to be incorporated at the concept inception, and frequently that is not the case. I will also point to the fact that there's evidence that there is an adequate reward to researchers who choose to conduct health disparities research. I can tell you from my own personal experience that my H-index is driven primarily by my non-disparities work. That is, the amount of time I have to put into a paper to get it accepted at a high impact journal when it's on disparities, I would say is significantly higher than the amount of time I need to spend on doing traditional outcomes research. Furthermore, the difficulty with publishing work like that is how often it's going to be cited and by whom. It is the case that disparities researchers tend to cite each other, but they're less likely to be cited by people doing more traditional research And that is something that contributes to H indices and evidence of quote unquote impact as well. Finally, we don't know what we don't know. And in healthcare and in surgery in particular, I would argue, there is a reticence to embrace ambiguity. And people are often called upon to review research that they are entirely inadequately prepared to describe and communicate to editors. As an example, I wanted to share with you a review from a recent manuscript that I submitted that was ultimately published. But this is a review from one of the reviewers, where I was trying to highlight the idea that there was too much heterogeneity amongst Hispanic Americans to always be having them aggregated as one group. And this reviewer did not seem to think that was something that was important, and basically called upon us to think of these as just simply political designations and to move on to proper science. And this review was from the very well-regarded Journal of Cancer. And I say this as someone who's published in Cancer subsequently, but nonetheless, when you have journals of this type of repute employing reviewers who don't know what they're doing and don't know what they're talking about, it means that Disparities research is not going to come to the forefront, not going to make it into the hands of people who need to read it. We have to do better for a number of reasons. One, conceptual blind spots with regards to how ethnic and racial minority disparities can be perpetuated can lead to poor study design, as evidenced by what we saw with the first coronavirus vaccine trial. They didn't even talk about how they recruited their participants in that New England Journal of Medicine article. And you have to question then, how were they even thinking how buy-in was going to work? How are they going to convince people this was something that should be trusted if they weren't even paying attention to the ways in which they were recruiting people at the very beginning? Without the representation and diversity amongst the people who are included in research, we have concerns, therefore, about generalizability to the greater public. As America becomes a browner country, we need to think about whether or not the research that we conduct will truly treat the majority of people in this country. We run into the constant problem of using race and ethnicity as a proxy for genetic variation. As many of you know, race is a social construct, not a biological fact. Nonetheless, it is a powerful shaper of our lives and of our research and of health outcomes. Just because it's not rooted in biology doesn't mean it's not important. And if you're only dabbling in health services research related to disparities without having a true understanding of what race means and how it operationalizes health, then you're in danger of ascribing a biological power to an important social force that's inappropriate. For people who don't believe that disparity is important, we then have the challenge of trying to convince people that disparate treatment actually leads to disparate outcomes, and that can affect costs. And that's something that many of us are finding we have to do because we can't simply appeal to a common view of justice to get work done. And finally, demography changes while power sleeps. Despite the best interests of some of our country who believe that America should not be moving towards a browner and more equitable and more diverse and inclusive society, that change is happening. And it is at our peril for us not to investigate ways in which to treat all people, that we will perpetuate research that in the end treats fewer and fewer people in this country and treats them less well when they present for care. Of course, it is the right thing to do, but moving beyond whether it's the right thing to do is the question of how best to do it. I'd like to offer a framework of better science as I conclude, because our world has been shaped forever by sources both viral and social. And we're conducting research in a changed world, which represents both a crisis, but also an opportunity to get things right now at a new beginning. We need to partner with primary care, which is often excluded from research enterprises, in order to capture the individuals who are being left behind by clinical care and by clinical research. We need to partner with federally qualified health centers. We need to work with health departments at state and city levels in order to get people enrolled in trials. We need to explore and embrace new sources of data, including ones being provided by the National Institutes of Health. N3C is a new collaboration that was developed in order to better capture COVID-19 data across the country. It uses the OMOP data model as well as electronic health record, and is partnering with CTSAs across the country to try and source data even from areas that don't have CTSA. Now, there are of course pitfalls to this, namely, these are going to be concentrated academic institutions, and how will these institutions be approached? How will they approach other institutions that may not have CTSAs in order to get their data and to verify that it is accurately and clearly representing the racial and ethnic information that patients want to communicate. All of Us is yet another NIH-sponsored source of data, which is really supposed to be a way to get a broad swath of society to contribute health data as well as clinical lab data to further precision medicine. But one of the issues with this project is that there's a real concern for volunteer bias. Yes, there's a website that's available for all, but is it something that people might be concerned about signing up for if they don't have documented immigration status in this country? And how might COVID-19 affect the way in which people can actually participate in these trials and contribute their data or their specimens? And finally, a third option that's also a way to have publicly available data is the BioData Catalyst, which actually combines data across NHLBI trials from the NIH in order to have, again, data that can allow us to study genomics and further precision medicine as we try to move towards a better, more targeted approach to various types of condition, both with regards to cancer and other types of disease. Now, the challenge here is that these are historical trials, and historical trials will, of course, incorporate historical biases of enrollment, as well as definitions of race and understandings of the contribution of race and ethnicity to outcomes. So are we in danger of potentially perpetuating disparity by using those types of previously gathered data? Now, as a final call to arms, I would argue that what we need to do in order to further a more inclusive approach to research is not only think about who we're including in our studies, but who's doing it. Who are your collaborators? Are you thinking about the fact that in this COVID-19 era that we're just gradually emerging from, that people who are of color, people who are women, people with young children, people who are responsible for elder care are less likely to have been able to be quote unquote productive during this time. Yet they may be some of the people who are most able to contribute in important ways to research related to disparity in this changed world. Who is recruiting your patients? Are they thinking about the types of therapeutic misconception we've discussed before? And how are you incentivizing patients in a way that is not potentially exploitative? How are you measuring social determinants of health? Is that being built into your electronic record? And are you making sure not to conflate race and genetic ancestry in developing your hypotheses and reporting your results? And finally, as we move away from a period during which race and ethnicity has been held up as kind of a shiny toy, frankly, by a lot of editorial boards for a lot of fancy journals that nonetheless continue to make mistakes with regard to their messaging around racism and discrimination in this country, are editors going to move beyond simply stopping and decrying racism and publishing editorials about it, and actually moving towards publishing original research that actually moves the needle and provides interventions for disparities that we see? I would argue that at the nexus of microcosm, trustees, and delegates in terms of what we are as representatives of the United States and other parts of the world in conducting research, we need to be at the intersection of all those sites. That is the path towards inclusive research. That is the path towards better research. And I would like to believe that we're getting to a point where we can all agree that's something we should prioritize. Thank you so much for including me, and I'm happy to take any questions.
Well, thank you so much for sharing with us. I definitely learned a lot, Dr. Fayanju. We have just a couple minutes, so I'll share a question from an attendee. And they asked, have you seen this type of bias in the practice of medicine as well, not just the research? And are there biased practices in delivering healthcare that emphasize whiteness that you have noticed, maybe through your research or through otherwise?
So unfortunately, there is significant bias in clinical care, ranging from things like the way in which pain is treated and the way in which pain prescriptions are prescribed, all the way to the extent to which physicians work to optimize health outcomes in people of color. So for example, we know that there are misconceptions to the extent to which Black people feel pain, belief that Black people feel pain less, and therefore they are given less medication after surgery for pain, and they are more likely to be suspected for trying to abuse the pain medication they're provided, even though there's no evidence that there's a racial difference in that utilization of postoperative pain medication. In addition, we know that primary care providers and endocrinologists often embrace different standards of optimal health for patients with diabetes. That is, you take two individuals, one Black, one white, with similar levels of challenge with regards to insulin provision and blood glucose control. And it looks as if clinicians are willing to settle for less good hemoglobin A1C measures, which is a measure of efficacy of glucose control based on the glycosylation of hemoglobin and red blood cells, which turn over every 3 months. And so it's basically a measure of how good blood sugar control been the preceding third of the year. And we know that in terms of striving to optimize medication, both insulin as well as other types of non-insulin medications, primary care providers, endocrinologists, clinicians are willing to settle for less good options or less good targets in their Black patients. That is to say that we definitely see biases in health outcomes, biases in the way that work is conducted, biases in the goals of care. And that is something that we really need to work against. And the patients aren't even, I would say providers aren't even aware of, even as they think that they're providing equitable care, they're not.
Yeah, that's terrifying, but thank you for joining that. And thank you tremendously for such an engaging presentation. So if anyone wants to continue discussing this work with Dr. Fayanju, we are having our breakout session at